of your final grade. We've got humanities, which is unprepared. No, that was the last one. This one is Epiphany. Has everybody read it? I mean, be honest, guys, if you haven't read it. It's not due. It's due Thursday. What do you know? Okay, so it's a good story. You'll get a kick out of it. There's some really good, you'll learn some new language. There's some really good words in there. And it's already on D2L in case you hadn't noticed. The SOAP note. Okay, so what we're going to do, we're going to have a pediatric patient experience. And I am so excited to be able to do this for you. And quite frankly, I'd love to take full credit for it, but it was Dr. McNeil's idea. The Tuesday before you go on Thanksgiving break, all these kids are out of school. So Professor Reggio, Professor Brooks is bringing their kids up here. Anybody know Kelly Williams from the, yes, she's bringing her kids up here. And they're going to be here that Tuesday afternoon, and it's going to be super informal. It's going to be here in the classroom. We're going to have a handheld otoscope, dress for clinic, but please no white coats. That's, if you go to a peds office and they tell you to wear white coats, try not to have that look on your face like, are you crazy? But anyway, so we don't wear white coats in peds. That's because it's usually scary to kids. But dress for clinic, no white coats, bring your stethoscope, and we will just informally do exams on these kids. Mainly, I want you guys to get a good ear exam, okay? All of these kids are provider friendly, so they're not the kids that freak out every time they pull in the parking lot, okay, of the doctor's office. So that'll be good, and what I want you to do is just write up a simple SOAP note. This isn't like your other SP notes, this isn't a huge thing. You're going to write up a simple SOAP note. You're going to talk to the child, get as much as you can from the child. They're going to have a presenting problem that you're going to pretend to treat in this visit, even though you might not see evidence of this presenting problem, okay? And then you're just going to write up a simple SOAP note. The subjective, the objective, the assessment, and the plan, okay? Don't need to include all the family history or anything like that, but get as much information from the kid as you can with a little bit of support from the parent, but it's anything that you don't get, just make up, okay? But basically, I want to see you treat this presenting problem and correctly treat this yes, we want you to correctly treat this presenting problem, okay? All right, and we'll talk more about that on the day. That morning before, I moved my, the PED-specific behavior issues, I moved that to that morning as opposed to the last 2 days. Because the exam is going to be on the Friday, so you guys have a nice, free, clear weekend before you start capstone, the exam is going to be Friday afternoon. We're having no new material presented after the Tuesday of the last week of the course. So rather than have 2 full days, I went ahead and backed my behavioral medicine lecture up a week just to make it a little less new material for you. Sorry that Tuesday's packed so full, but that's just the way it worked out. And I think you'll be okay. Study up, stay up with the study, and even though we're having only 1 exam, and you'll be just fine. Because PEDS isn't, while it's a little bit, it's different than adult medicine, it's not exactly new medicine. You guys are familiar at this point, okay? I want to tell you guys something. I went to, I was telling some of you already, I went to my husband's ortho appointment with Gene Fountain over at McBride yesterday, and he was raving about your upperclassmen, your 18ers. He's had 4 of them through on rotation, and was saying he was just so excited. One of them has a job if she's interested, so he was just super excited about taking our OCU students. And he said, and I hate to feel good about stuff by dissing somebody else, but I might. He said one of his colleagues, Don Flynn, had an OU student, and Don was out of the office for a few days, so he asked Gene to take the student for just a few days, and he said the difference was just night and day. He said that OU student, now he could have just been a knucklehead or something, but he said that OU student didn't even know his surface anatomy, so he was just, he's so pleased with you guys, and I told him I felt good about that. It was nice to hear. It was really nice for my husband to hear too, because he thinks I just come up here and sit around with my feet up and eat bonbons all day. All right, so All right. Oh, we've already kind of talked about the pediatric patient experience. It's going to be real informal, guys. The kids are going to be coming in. Thank you for joining us today. Appreciate it. Sorry, I had to pull out my inner McNeil. Okay, so anyway, so the peds patient experience. The older kids will be here at 1. Some of the younger kids, we've got, I think our youngest kid that's coming is probably Kelly Williams has a 2-year-old, and then Professor Reggio's kid is 2. I think those are the 2 youngest ones here. They're coming after 3 because nap time, you know, so, all right. Okay, so let's see here. This Let's Talk Classroom, this was more about last year. Last year, at this point, we had a problem with attendance, but you guys have been rock stars, so I don't need to even worry about that with you guys. Does anybody have any questions about the course in general? Okay, yes?
You said the PEDS exam would be the afternoon of Friday, but...
No, it's Tuesday before Thanksgiving break.
The PEDS exam.
The PEDS exam.
Oh, I'm sorry, yes, the PEDS final, I was thinking pediatric patient exam.
So is it not the time that's set?
I had it at 10. I think, well, actually, you guys can decide. Do you want it at 10? Do you want it at 1?
Yes,
Do
10.
you want it at 10 so you can leave for the weekend? I don't know. Okay, that's fine. We can do it at 10. I got no issues. Yeah, 10 will be fine. Do I hear grumbling? Okay, all right. That's okay if I hear grumbling. I can handle grumbling. I'm good with that. All right. Okay, really, any questions about anything? No? Okay, great. All right, let's talk a little bit about how we approach a pediatric patient. Okay, it's really important to remember that peds are not just short adults. They are developmentally, they are not developed emotionally, physically, mentally, they're just not short adults. But the one thing you don't necessarily have to do with peds patients is talk down to them. You want to use simple words, which is why I lost all my big words in the last 11 years. But you want to use simple words, but you want to talk to them in such a way that they do understand. And I thought this was just a funny little cartoon. The early bird gets the worm. Right? Okay. All right, enough giggling. Oh my God, there's 2 really cute pediatric patients right there. That's my grandkids. That's Isabella Grace and Morrison Paul. That's a few years old. They're 9 and 5 now. Look at that belly. All right, when you're getting a pediatric, when you're doing an H&P on a pediatric patient, it's really important to start at gestation. So get a prenatal history. You want to know if there was any complications with the mother's pregnancy. Was the baby premature? Were there any abnormalities on ultrasound? Most moms or parents are really happy to share that with you. If the clinic uses a pre-printed form, you know, a history form that they sit out there in the waiting room and fill out forever, acknowledge it, you know, actually let the patient see you look at it, make notes, ask questions. A lot of times they don't go into enough detail on that form, ask questions about it. Be sure that you're picking up on nonverbal clues coming from the parents. Sometimes you can, you know, sometimes it's easy to be presumptive. You know, we all have those unconscious biases. So be conscious of your unconscious biases and pick up on verbal clues that the parents might be giving you. Okay, also understanding the family is a huge part of pediatrics. It's a huge part of practice in pediatric medicine. Some families can look like this. It can be a mixed race family. Some families look like that. That would be my son and my daughter-in-law and Isabella and Morrison. Look at that attitude. Oh dear heavens, he is adorable. Looks just like his daddy. Some families look like this. You know, sometimes they have 2 dads or 2 moms, you know. And some families look like this. A lot of times we're dealing with grandparents. The biological parents might be completely out of the picture. I like to refer to the parents by name. I get really tired, I got really tired of being called mom by people that I didn't know. You know, that's one thing, if I know you and you want to call me mom, I have plenty of kids that do that. But, you know, respect the parents and You know, just like you're taught. It's amazing how we're teaching this. Just like you're taught, ask how would you like me to address you? Also, it's really important, a lot of times parents are raising their kids with respect for their elders, not all of them, but some of them are raising their kids like that, and they want to call you something other than your first name. So in my pediatric practice, I was referred to as Miss Susan, because you're ethically and legally obligated to correct anyone that calls you doctor, so they didn't want to call, so Miss Susan was my title in the peds, so a few of the special ones called me Yaya. Okay. Things that's unique about pediatric histories is they're generally obtained from a third party. Anytime that you have information being filtered through a third party, it is just that, filtered through a third party, so they're giving you their interpretation of what they think is going on. So that's something to be aware of and conscious of. A lot of times I've heard pediatrics referred to as kind of a little bit like veterinary medicine, because the kids aren't able to tell you exactly what's going on. So it's kind of your best efforts to figure it out, and through your careful physical exam. Make sure that you're not imposing your opinion on what they're trying to tell you. Try to listen to them. When the parent gives you, especially a medically complicated child, maybe a developmentally delayed, like in the ER down in Duncan, there's this one kid that comes in occasionally, not very often, but comes in occasionally, and this kid is like five now. And he's developmentally delayed. He has congenital dwarfism and hydrocephalus. And the mom is always so excited when I'm working, and she comes in, and I saw the kid again this weekend. And, that always makes you feel good, because that mom, bless her heart, she tries to explain to me what's going on, but she doesn't always understand medically everything, how to say it appropriately. Kind of like me sometimes. But. All right. Any questions so far? Okay. As far as an actual physical exam on a kid, they generally don't like to sit up on the table. Sometimes they will, but I've done just as many physical exams on kids with them sitting on their parents' lap as I have with them sitting on the table. So be flexible. I don't like the otoscope and the ophthalmoscope that are attached to the walls when I'm doing peds. I like the ones that are more movable, because you need that flexibility. Sometimes it feels like you got to stand on your head to look in a kid's ear, but that, at least if it's not attached to the wall, that gives you that range of motion that you need. Remember to go slow. While you know that you're a safe person, the kid doesn't. So a lot of times you're going to see the kid you'll be talking to the patient, and they keep looking over at their mom. I mean, I've done well child checks as young as 4 months old. Once I move closer to the baby than the baby's parent is, they'll look at their parent like, is this okay for this stranger to be all up in my business? And I always point that out to parents, that that's a very huge social development phenomenon that basically lends itself to say that this kid is not going to have autism. They're not going to be on that spectrum as young as 4 months, because the whole autism MMR thing, have you heard that story? Yeah, that Crocahooey there. It was actually denounced. I mean, the guy lost his medical practice over it. I've never really trusted the Lancet since for publishing that original article anyway. But when you've truly got an autistic kid, a good provider can pick up on that as young as 4 to 6 months old. It's just that at 12 to 15 months is when the parents really start noticing things like that. So I used to have this one patient that I'm kind of loud. in case you never noticed, but I'm kind of loud, a little rambunctious, and I would just kind of open the door and, "Hi, how you doing? Good morning." And I made this one little 9-month-old girl who's obviously from a very quiet household, very subdued. I think both her parents were librarians, honest to God. And she cried, and for like, it took me like 2 years to get her to not cry when she came to the office after that one episode. So that little girl taught me a whole lot about approaching a pediatric patient. So I always knock because you never know what's clinging to the other side of the door. Open the door slowly and then kind of let the kid set the tone. If they are bouncing off the walls, well then I can be my normal, loud, rambunctious, rowdy self. If they are, you know, clinging to mom and very subdued and quiet, well then I take a totally different approach. You guys will get the hang of that. It's not rocket science. So a lot of times, like I said earlier, we use the parents' knees as our table. I like the stools on wheels because I'll scoot right up to the parent that's holding the child, my knees to their knees, and then I can lay that baby down up to 3 years old and, you know, do whatever I need to do with that kid like that, and they're still very safe because they're like this, hanging on to mom. So, save anything that is very upsetting until the very end. I usually look in their mouth. Well, I don't look in the mouth at the very end. I always check their genitals at the very end because then once your hand's dirty, you gotta get up and wash them again. But you know, I usually look in their mouth at the, towards the end of the exam because most kids don't like that. With peds patients, you guys have learned to hold the otoscope like this. Some of you I've talked to, I use the kind of the pinky technique on the patient's cheek. You guys know what I'm talking about? That way, the kid's head jerks, the otoscope doesn't ram into their ear. You give, one kid jerks their head, gets an otoscope tip rammed into their ear, and you'll have 8 years of horrible ear exams on that child. So I like that pinky technique, so if their head moves, my hand moves with it. Does that make sense? Okay, so that's what we'll be working on that Tuesday afternoon before Thanksgiving. It's awkward at first, but you'll get used to it. I mean, I got 70-year-old people that do that same thing. Oh, there we go. Look, I even found a picture of it. Isn't that amazing? Yeah, because that really does work. Fever and peds patients. It always drives me crazy when the mom says, "No, I didn't give them Tylenol this morning because I wanted you to see how high their fever was." No, really, I trust you. If you tell me their fever was bad, I believe you, you know. So peds patients can be very, very sick and not have much fever at all. And they can be not very sick at all and have a huge high fever, okay? So fever is not an indicative of degree of illness, and a lot of times parents don't understand that. Parents are often concerned about pediatric febrile seizures. They think about them, they're scared by them. It's not how high the fever goes that causes that seizure, it's how fast it gets up there that causes that seizure. So, and also when a kid, you know, I generally don't recommend, we don't really call it a fever until it's over 101 or so, you know. Parents will call it a fever at 99.3, so you just smile and say, uh-huh. And, you know, but I generally don't recommend dosing Tylenol and Motrin until it gets around 101 because, you know, fever is your body's way of fighting infection or viral illness. You know, try to keep a kid fever-free and they'll just stay sick longer. Although the text, you know, the recommendations now are, there's no harm in treatment for any degree of elevated temperature. So whatever the parent's comfortable with. Sometimes they don't like to give their kids medicine and then that's fine, okay? I spend more time in peds actually talking the parents out of antibiotics than I do writing prescriptions for antibiotics. Because everybody wants that magic pill that, you know, and I just flat say, I'm sorry, I left my magic wand at home today. I can't wave it and make your child better for daycare tomorrow. It's just not gonna happen. I'm really sorry about that. You know, so, you know, when a kid needs an antibiotic, I would, you know, of course, they're going to get an antibiotic, but a lot of times you got to explain to a parent why green snot in the morning doesn't need an antibiotic. green snot all day for 4 days, yeah. But, you know, green snot in the morning, not so much. Okay. All right, anybody have any questions? I actually took longer than I thought I was going to, 30 minutes. This is like a marathon for me, guys, right? So we got a little break. Laura Shao is, oh, this is really funny. This is hashtag stuff we never did with our own kids. Paul and I just went up to Minnesota a couple of weeks ago, and we took the grandkids to the arcade at the mall. Never did that with my own kids. We took them to Chuck E. Cheese. Never did that with our own kids. And we took them out for ice cream twice. Because we're the grandparents. Okay, so, all right, we got a little break. Laura Shao will start at 9 a.m. She's going to be, I don't know, I know she's doing pediatric respiratory illnesses and infectious. Yeah, there you go. Very good. I'm glad somebody read the schedule. All right. As usual, I'm going to be with you for all your lectures, even Dr. McNeil this afternoon, because I don't know, it's kind of fun to listen to him. It's kind of fun to sit in his classroom again. But I'll be with you at all your lectures. I'll be taking notes to write the test from. So if you guys have questions, I'll be paying attention. If I ask questions, you be paying attention, and we'll get through this together. All right? All right, you guys have a little break until 9. Thanks for showing up.